Good afternoon, everyone, and thank you for joining us for our first quarterly update of 2021. Today, we will be sharing updates from major events of 2020, as well as what we think should be paid attention to in the year ahead. So before we get started, I wanted to do some quick housekeeping. So we really want to make this participatory, and part of the intent is of bringing the whole team together on a call is so that you can ask questions and get multiple perspectives from everyone. So as you're submitting your questions, please think about topics and themes that multiple analysts might be able to answer. But if you want to ask something specifically to one person, that's fine as well. After we finish this, there will be a survey redirect at the sign off. So if you could complete that, that helps us improve each one of these sessions, time over time. We will be sending out the recording of this for you to rewatch and revisit or share with your colleagues early next week. This year, we are also doing a lot more video production overall, and therefore our YouTube channel will be much more active. And if you like to receive content in video format, we highly suggest you take a moment to go over there and subscribe so that you receive notifications whenever we publish something new there. And finally, I wanted to let everyone know that as part of our production cycle this year, we are going to start running 2 webinars to accompany the release of any of our research reports. One of those webinars will be a sponsored webinar featuring vendor executives sharing what they've learned from working with clients. And then the other webinar will be an end user webinar where we will feature people who are actually working at the front lines, sharing what they've learned through their implementations and actually using the systems. So if you have any interest in submitting a client or sponsoring one of those related to the research we're doing this year, please reach out and we can discuss. So a quick little about Chilmark Research for those of you that are newer or less familiar with who we are. We view it as our mission to help organizations adopt, deploy, and utilize modern information technologies to improve the healthcare experience. Our team is united by a core belief that effective deployment and use of IT is essential to modernizing care delivery and improving the care journey. So we look at the trends and the regulations and new technology innovations that are helping to reshape and reinvigorate how care is delivered in this country. We do this with very comprehensive, in-depth research. And if you're familiar with that research, you know that we're one of the kind of deepest health IT evaluators out there. So we try to view ourselves as the organization that's able to bring clarity to an uncertain time. So for today's agenda, we'll be starting with John Moore, our founder, talking about the long shadow that 2020 cast, followed by Jody Rank, who will be discussing AI and analytics, Brian Murphy, who will then be discussing interoperability, and finally, Alex Lennox-Miller, who will be discussing what he'll be looking at in distributed care. Then we'll be following that with the discussion and Q&A. So please hold your questions until the end, but feel free to submit them throughout the webinar, and we will address them when we get through everyone's presentations. So without further ado, here's John.
Well, first off, while John's fixing that, I'll go ahead and start. As you probably figured out, John's my son. He's been a great addition to the team and does a lot of our growth strategy work. And that includes ensuring that our clients are getting the most value from the services that we provide here at Chilmark Research. Getting to my presentation, I really, the title of my presentation is, COVID casts a long shadow. I think the shadow of what we've seen with this pandemic is far from over in 2021, and the repercussions of the pandemic will extend out for many years to come. So first slide, John, next slide. So the COVID's impact, it continues till today. The financial stresses on provider organizations are certainly being felt. We even saw in fourth quarter results coming out of payers that they're starting to feel a bit of a pinch from COVID finally. They profited quite handsomely up until the fourth quarter due to the elective procedures basically being put on hold through a good part of the spring. And honestly, members' reluctance to go to the ER when they had something, they didn't feel right. The last place they wanted to be was in an ER full of COVID patients. So those stresses to provider organizations continue into today. I believe what's going to occur as a result of that, not to say we haven't seen plenty of mergers and acquisitions already in the provider space, but I think in 2021, you're going to see an acceleration of mergers and acquisitions amongst providers. And in particular, I think it'll be led by, providers will certainly play a role in some of those acquisitions, but it's also going to be led by private equity firms and payers that are targeting the ambulatory sector, because that's the next big area of growth, or it's becoming so. In fact, some recent research from Ziegler reported that one of the emerging markets that are of provider organizations that are being acquired, ambulatory organizations is primary care. So primary care is finally getting its day in the sun because it's been overlooked for many, many years. But with the advent of value-based care, it is driving primary care's importance at the expense of, honestly, specialty practices are not seeing the same level of interest as they used to get. That may change a little bit now that CMS has made 1,700 plus acute only procedures now able to be done in an ambulatory setting, so basically site neutral. I think that'll also encourage more acquisitions. These are going to be also accelerated, with the migration to this whole thing of financial stress. One of the outcomes of the pandemic has been that, those that were in some sort of risk-sharing value-based care model, those provider organizations that were in that tended to weather the spring much better than those that were being paid on a fee-for-service model strictly. So I think we're going to see that continue to increase, move to value-based care as a result of the pandemic. I think we can't ignore clinician burnout. There's incredibly high stress on clinicians today. And, that includes the nurses. Basically, in many most of the country is hard hit at this point. You can't even find the staff to staff some of these places. And even here in Massachusetts, they announced just recently that they're going to bring back retired nurses and physicians to administer the vaccine. So I think, clinician burnout is a very real thing right now with the pandemic, the emotional stresses it's put on our providers, the staffing cuts, et cetera. It really remains to be seen what the actual fallout of that will be. We'll have to wait and see, but I think it's something we can't ignore. And lastly, the rise in behavioral health as a result of the pandemic. We've seen a lot higher interest in behavioral health. Of course, that ties back into value-based care and chronic care management. Certainly, you can expect more merger and acquisition activity in 2021 around this area. Centene's acquisition of Magellan to serve mostly Medicaid population is a fairly recent large example of such an acquisition in the behavioral health space. But you also had smaller acquisitions such as behavioral health provider, digital health provider Able2 was acquired in 2020. They didn't announce exactly who acquired them. That's been kind of kept under wraps, but the rumor has it that it was United Health Group through its Optum division. So, and we're seeing, as a target for digital health funding, behavioral health is really top of mind for many investors today. Next slide. Okay, What the pandemic has done is put digital health, similar to primary care. Now they have their day in the sun. And what I think is really phenomenal here is, everyone complains about how providers don't adopt technology. And this is oftentimes leveled at their use of EHRs. Well, I think what the real rub is that if it's needed, if it helps them with their practice and delivering care to their patients, they'll adopt it, and they'll adopt it very quickly. We saw the rapid adoption of telehealth occur. For example, Epic, which basically reported almost zero telehealth visits in February. I mean, it was in like a couple thousand at most, if that. Well, anyway, by April, 69% of all visits were being recorded in Epic across the Epic ecosystem. 69% of them were telehealth visits in April. So basically, you went from 0 to 60, almost 70% of all visits being telehealth. That has calmed down once we got past that lockdown phase that we had in the spring. But even in July, Epic reported 21% of all visits were still telehealth visits. So I don't think it's going anywhere. And it clearly shows that if given a reason, providers will adopt technology very quickly and will deploy it quickly, and it will get used. So I think it points to, when we think about digital health and IT and healthcare to improve the delivery of care, we really have to keep our mind on what are the incentives. Are there alignment and incentives that will help this technology see rapid adoption? Funding increased. According to a recent Rock Health report, looking at 2020, we basically increased year over year spending on investments from PE and VC firms in the digital health space. 75% increase, or representing $14 billion. There weren't more bets being placed necessarily, but the deal sizes increased substantially. And I think that's because once the vendor, these investors find a company that they think that they can go to, that has some runway to it, they're putting more money behind it to make sure they succeed. I think we're also seeing the rise of virtual care platforms, something that Alex will touch on later. That will be broad, scalable, and single source for meeting, say, the wellness and health requirements of a large employer. I think that's part of the strategy behind the Teladoc Livongo acquisition, wherein Teladoc spent $18 billion to acquire Livongo, which was a very, very large multiple of revenue. We're also starting to see the advent of virtual primary care plans from the payers, where it's kind of, a telehealth first or virtual first care plan, a health plan. And there's incentives around that and cost savings that people can now buy into. The big question, though, that I wonder about is, will digital health help address disparities? That's one thing about COVID. We've seen massive disparities in how healthcare is delivered and accessed. I remain unconvinced that the technologies and the digital health technologies we're taking to market today, if they actually help address disparities with access capabilities to care providers, or does it increase them because of the need for the technology that many simply don't have access to? Next slide. So in closing out, I just wanted to give a couple points on, we have a new administration, we've got new priorities. certainly the COVID response, the vaccine rollout is top of mind. And that's going to be going on for at least the first 6 to 8 months. That's not to say they're not going to be doing other things with the administration, but that's top of mind. You know, how do we make sure everyone's wearing masks, get the vaccines, you know, shots in arms, and address the new variants that are starting to come up from, you know, I think it was today I read that the South African variant was found in the United States now. And there's a Brazilian one as well that was recently found up in Minnesota. So there's a lot of concern about these variants and what they could or could not, you know, do the new vaccines that have arrived in the market, do they address these variants as well? And early signals showed that they actually have to do kind of a booster to these vaccines to address these new variants. Disparities will become a focal point for this administration. Medicaid and social determinants of health will be top of mind to address disparities and also access to care. That's going to be a really key point of the Biden administration. I think there's also going to be greater scrutiny of provider M&A activity. It's important to note that the HHS Secretary nominee, Xavier, let me see, I got his name here somewhere, Xavier Becerra, he was the Attorney General in California, and he was the one that filed the lawsuit against Sutter Health in California, in the Bay Area, for its monopolistic pricing practices in that area because of how many physician practices they had acquired and their ability to drive pricing up in that area. So you can expect greater scrutiny. Even before the Biden administration took the helm, the FTC made an announcement that they were asking for claims data to review and look at pricing and pricing comparisons pre and post acquisitions of various providers or hospital groups. And I put a link in here in the slide deck. You can find further legal analysis of what this all means from this one firm, Ackerman LLP, who did a pretty good job of outlining that. And lastly, CMS has been the leader in value-based care models, testing those models through the CMMI program. A lot of those models simply did not deliver. And there was a recent report published at the beginning of the year from someone at CMMI. He was the leader there at CMMI, looking at where they were able to get value and where they didn't. And I think, there's so many, when you look at CMMI, there's so many models they've tested. There really needs to be a rationalization. There's bipartisan support that we must bring down the cost of care. And so right now, they're still pushing. I think the Biden administration will continue to push value-based care models, but simplify those and make them two-sided risk models, because those have been found to be delivering the greatest value for the money spent. So we'll have to see what comes of that. But there's bipartisan support, as I said, for controlling cost of care. And if we can't do it through value-based care, then, and providers' adoption of such, then we will probably have mandated price controls. And no one wants that, particularly hospitals. They'd like to have a little bit more control of their destiny. Anyway, that finishes up my presentation, and I'll pass the baton to Jody, who will take over talking about AI and analytics and a little SDOH as well.
Thanks, John, and good afternoon, everyone. So if we look at 2020 and the work I've been doing on AI and analytics for Chilmark, we began the year with a report I did on, it was a sort of a market scan of about close to 120 companies in the AI space and who is doing what across all the verticals in healthcare. But in addition, I looked at a lot of the challenges and innovations within AI. So everything from the issue of bias in algorithms to the use of federated learning and differential privacy, the work in academia that's being done on new causal models that could be useful in clinical care, and so forth. So it's a very broad view of the space. And then shortly after we released that report, the pandemic hit, and you started thinking, well, what is the impact of the pandemic going to have on AI and analytics? And one of the first areas we began looking at was this issue of the bias that we highlighted in the initial report, because we saw, Black Lives Matter, and then the way the pandemic was unfolding, and the disparities in across race and ethnicity. There were a number of interesting issues that came out of that, as well as solutions that we began to see pop into the market, or people responding to, taking existing solutions and responding to that market. So for example, we had a webinar with Prealize where they were looking at, what they were focused on is identifying patients at highest risk from deferred care under lockdown conditions, who would, you have to reach out to as you came out of lockdowns to avoid hospitalizations and so forth. We also saw Javion creating a kind of heat map on by neighborhood, by bringing together EPA data, census data, all these various layers of socioeconomic types of data, then being able to sort of map out which neighborhoods would be at highest risk for COVID outbreaks and so forth. So we began seeing the way AI was responding to the crisis, but at the same time, some of these long-going issues around AI and racial bias rose to the forefront more. More data scientists and really focused on how do we address this, because we're dealing with some historical issues and bias in clinical research. That data can now get integrated into the training sets that we use to build our algorithms on. So what do we do about that? And where do we fill in the gaps in data? And one of the more interesting issues looked at was also, everyone's interested in wearables now as part of remote monitoring, so forth, but most of them use green LED, which darker skin absorbs the wavelength, and you're introducing error at the point of data collection. So looking very deeply into this issue of bias in AI. We also saw some moves from the FDA on a maturing set of guidelines about how AI and algorithms will be regulated going forward, and responding to that issue, how AI algorithms continually learn, so you don't have, you won't always be able to lock down the algorithm. So how are you going to respond to the algorithmic changes that algorithm from a regulatory perspective, and thinking about risk, and then post-marketing surveillance of how these algorithms evolve. And this is going to be quite important as we think, about some of the work like Alex is doing with virtual care. As virtual care, you have more, in the future, we're going to have more and more remote patient monitoring tools in the home or on the body. That regulatory environment is going to be very important to follow, and we're seeing, a lot more investor interest in these RPM technologies as well. And then once again, going back to the social determinants of health, we issued a report in the fall looking at vendors who are integrating data about community partners into the point of care for providers to sort of to reduce that friction in getting the data on who's doing what that can address the social determinants beyond the clinic. If we go to where we're going this year, to the next slide, from all of that work on AI, we realized that one of the critical areas where AI could respond to the pandemic is area of operations and reducing the administrative burden and addressing workforce challenges that the pandemic created, as well as supply chain. So later this quarter, early second quarter, we're going to release our report on AI and operations. So if you have any thoughts on that, please reach out to me as well. And then with Biden, the new Biden administration, he's already assigned or given the role of to Dr. Nunez Smith from Yale Medical School or School of Medicine to lead the COVID-19 Equity Task Force in highlighting the importance of social determinants and policy formation going forward around COVID-19. So we expect to see new funding opportunities and a lot of pressure to address these social determinants, unlike what we've seen to date so far. And linked to that, I think this AI and ethics and bias will continue to be a major challenge, where we haven't gone more than a month or two without major journals coming out with reports in Science and Nature, New England Journal of Medicine, of lots of clinical algorithms that have been found to have substantial bias. And I think the pressure to come up with solutions that address these biases. So on one hand, there's a technological focus on using AI to root out AI bias, but then also the human element of that and what's being done as an industry to address that. And the pandemic has also shed light on the tremendous gap between the health IT system and the public health information systems. And I don't know if any of you have come across the book by Joshua Gans on the economics of the pandemic, which he views that the major challenge is an information gap. And it's precisely this gap, and it may require the magnitude of the problem is so great, it may actually require a kind of, like almost a Marshall Plan in healthcare for buttressing the public health and health IT linkages. When you look at the overall healthcare budget in the US, only 5% has been spent on public health over the last decade or so. And our inability to address these data challenges, despite unprecedented data sharing with players sharing more data post-pandemic, we still have a major gap there that we need to fix. So I'll be looking for solutions and policy changes that can address that. And then just the growing role of AI in remote patient monitoring across pharma and remote clinical trials, drug development, and digital therapeutics. Who's doing what? We've seen some major investments in companies that have wearable devices, but their expertise is really in the algorithm development. And we're seeing a lot of interest, for example, in how wearables can detect the early signs of infection, COVID and otherwise. And so there's going to be there's been quite a bit of money put behind this from everywhere, from the Defense Department to NIH, and using these tools. But there's also an AI component increasingly within these devices, and in particular where we're seeing more of the sort of de-skilling of diagnostics, where you have a diagnostic that had once been used for, had to be used by a physician or nurse, and now you can put it into a layperson's hands, and the AI as part of is like de-skilling that and making it more usable by the patient or consumer end user, things like that. And that also has it's associated regulatory issues associated with it as well. So that's the AI and analytics piece in a nutshell of what I'll be focused on this year. And I'll go to, is it Alex next? Or Brian?
Hi, well, thank you very much, Jody. I guess just initially, I'd like to apologize to everyone that you're not looking at my smiling face right now. It's not only because I'm antisocial, which is clearly true, but I just wasn't able to get my webcam going. If it's any consolation, I can assure you, you're not really missing much. So 2020, obviously, you know, COVID, all the things that John and Jody talked about, but in a normal year, the most significant event of 2020 would have been the release of the Cures Act rules from HHS and ONC and CMS. And those rules, I think, as pretty much everyone knows, they focus on making it easier for patients to get access to their data, but the impact, those rules set a tone and a tenor, and the impact will be felt much more broadly than that. And just to back up for a second, I think it's important to kind of think about the approach that the feds took here and how it differed really drastically from the approach that we saw in the old EHR incentive program and the MU programs. Under MU, the approach to urging HIT vendors to improve their product sets was to say, here's a set of functions that you're going to need to get certified. So please have them by this particular point in time. And as ONC kind of ramped up those functional requirements, the resistance from the industry, I think, ramped up right along with it. So it sort of outlived its usefulness. Now, the Cures Act, the whole approach is completely different. It's really about focusing less on a specific catalog of functions and asking vendors to really get into the whole business of enabling the extensibility of their applications, primarily through APIs. Now, I think as everyone has kind of alluded to at one point or another here, we've got a new administration, and this new administration, I would say, would be more closely aligned to the approach that we saw under the MU program, but I feel like it's going to continue the current policy in some way, shape, or form. I mean, I think, you know, the days of a list of required functionality are gone. If I had to look into a crystal ball, I think one major difference that we might see in the new regime is a little bit more focus on enforcing the information blocking provisions of these rules. Some of that hasn't really been fleshed out or defined. So, and I think it's unlikely that you're going to see any kind of enforcement action here in the next year or two, possibly. The first round of people who are subject to these rules begins April 5th, I think. So, and that's 2 months away. So in any event, that this approach it is a real sea change in the sense that I think it democratizes this whole idea of development integration. It's not the exclusive province of developers of so-called certified EHR technology. So last year, we kind of dived into the APIs that are, in fact, are very similar to the ones that are required under the Cures Act. We looked at a whole bunch of different kinds of vendors. And there's a lot of stuff on this slide, and I'm more than happy to talk to anybody about any of it. But it is fair to say that if there is one group who is most anxious to consume these APIs, it is digital health vendors. Traditional kind of healthcare ISVs, clearly they're using it. There's a lot of companies who are doing kind of patient-related stuff, but the sheer variety of companies who call themselves digital health, and I'll be the first one to admit that that's a little bit of an amorphous category, but there's a tremendous demand for data by those guys, and they have a tremendous variety of different kinds of things that they're interested in doing. So this report is done. If we skip to the next slide, We will be releasing another report that takes a much broader look at the kind of integration and interoperability landscape in healthcare. We're calling it the Integration Infrastructure Market Trends Report. And as you can see here, it is a staggering array of kind of different capabilities, different functions, different standards. And we're trying to get a sense of where the world is with respect to supporting developers and integrators. Later in 2021, we're going to drill down on 2, possibly 3 elements that you see inside here. We're going to be looking at data aggregation, particularly as it relates to analytics and reporting. So that in addition to this report will be happening. That's probably the next report we've got coming up. And it will be a substantially kind of different set of vendors. Then we will we'll also be looking at messaging vendors. There are a number of different vendors who send messages with payloads around the healthcare system to accomplish various things. Direct is still a very big part of the information flow around healthcare, and direct is trying to do things to make those payloads more useful and more consumable. So let's go on to the next slide here. Just to give you kind of an idea of who's in this report that's coming out, hopefully in the next month or so. It includes all the major EHR vendors. It includes a whole group of companies who call them HIE stalwarts here, but there's a bunch of other companies who frankly support digital health really well that I would put into this category. And then the last group is the big cloud companies, which are amazing to me because they're very loud about what they can do in healthcare. Notwithstanding the fact that 99% of what they do in healthcare is really related to capacity and hosting various things, they are making pretty bold pronouncements about their ability to deal with healthcare data. They have tremendous tools for developers and integrators, but frankly, they leave a little bit to be desired in terms of their understanding of healthcare data and healthcare more broadly. Next slide. Every one of our reports has something called Chilmark Bearing, which is our take on kind of how these companies sort of, it's our high level summary of how they do from a product standpoint and how they do in the market. And so EHR vendors and the companies we call HIE stalwarts are really, they know healthcare. The big cloud companies who are massive and they are in everyone's future, probably less so. This is subject to change without notice, or we've still got a couple of weeks to go before we finalize this. But I just thought I would wet your whistle with a little bit of information about that you might find in this report. So, Alex, do you want to take it away?
Sure, Brian. Thank you very much. I think coming as a surprise to nobody, virtual care has been a major focus of ours over the past year and will continue to be going into 2021. As I think probably most of you know, I am working on a virtual care report. What we're focusing on here is trying to progress the conversation beyond what we know about the telehealth explosion that happened in 2020. That's been very well covered. Looking forward, what we see is an expansion beyond video telehealth into the virtual care tools that best support long-term care and chronic care. We've seen major vendors in the telehealth space start to, either through acquisitions or through partnerships, create broader platforms that include telehealth, include RPM, include analytics and other functionalities. John mentioned a couple of them. Those are going to be, we think, the model for how a lot of virtual care is conducted going forward. The most interesting thing about it, and this is again something that John touched on, is how important behavioral health solutions are going to be in that process. Behavioral health is a huge challenge. Obviously, it's a major comorbidity in most chronic conditions, a major obstacle to clinical outcomes, but it's also aggressively underfunded and seriously underaddressed. In 2020, we saw, I think, a 3x increase in overall funding in digital behavioral health, somewhere in the range of 1.8 billion. That is going to continue in 2021, and we're going to start to see the fruits of that investment with behavioral health solutions, particularly asynchronous solutions, products that offer options other than simply teletherapy, really taking a major place in the ability of platforms to assist and manage patients. Many of those platforms are targeted not just at providers, but at employers. They're being distributed by self-insured employers. They're being distributed by payers to support their populations. We expect that to continue. That exclusive proprietary relationship between, for example, the PCP and their patient is breaking down. Patients are able to access care from a much broader variety of places. They are receiving care from a number of different potential apps from different providers, and that is obviously simultaneously a real benefit to patients and a challenge as we enter into a more fragmented, more disparate virtual care realm. And finally, we would be totally remiss if we didn't discuss the 1,000-pound gorilla in the room. We saw, obviously, the collapse of Amazon Haven, but Amazon Care has, at the same time, really taken off. When we look at major telehealth or virtual care platforms going forward, Amazon Care is likely to be one of them. 2021 is likely to see the deployment of Amazon Care outside of Washington State, outside of Amazon employees, and that is going to be a major change in how people interact with the virtual care market. Can you advance the slide, John? The other major shift that we're seeing is the hospital at home shift. CMS has promoted this pretty aggressively throughout COVID and especially toward the end of 2020. Data coming out of the pilots and places that are trying this has been really encouraging. But this is really less of an individual specific drive and more part of a larger drive toward ambulatory care that John mentioned. Pushing treatment, pushing procedures out of inpatient facilities into ambulatory surgical centers, into outpatient facilities, and into the home. You advance the slide, John? Where we see this going is a model that we call distributed care. It divorces care from specific locations, in some cases even from a single provider network. We see patients getting care at retail locations, at urgent care clinics, accessing some chronic care platforms through their employer, accessing community support. All of those need to be tied together. That fragmentation has to be resolved at some point. When you tie that together into a single aggregated data structure, you have obviously a hugely important, first of all, resource for care, and second of all, a hugely valuable data set. We expect to see a lot of focus from vendors who understand the value of that data, who are looking at the ability to be that central aggregating source, coordinating and taking data in from a variety of different platforms, from a variety of different pieces of software and devices, from a variety of different in-person providers, labs, and testing, creating a profile and analytics that simultaneously support patients, help distribute and aggregate care, and really bring care into a much broader set of options than have existed so far. That's going to include not just RPM, not just telehealth, it will include solutions offering, for example, symptom checking and virtual triage, patient experience and consumer experience, and the kind of front door access questions that have really been of great interest to the industry, but have struggled to progress before 2020, when suddenly everyone had to pay attention to them. John, consumer experience is going to be my next area of focus. As I said, we see this as really central, not just to the evolution of patient care, but also to the growth of virtual care, distributed care, and those now increasingly interoperable and aggregated data sets. Certain factors like the requirements for price transparency and the provider need to drive a better upfront payment are clear drivers. They're one of the reasons that adoption and promulgation of these platforms is happening so aggressively. But the ability of those consumer experience platforms to perhaps play that central data aggregation role, tying virtual care platforms, chronic care, device monitoring, patient-reported outcomes, surveys, reputation management, all of that brought into a single data set, aggregated by a single system, is potentially incredibly valuable. And we're seeing a split between how companies are addressing that question. Looking at how vendors are approaching that, how they're monetizing it, and where they are predicting this to go is going to be a major focus of that consumer experience report coming later in 2021. So thank you so much for listening. I'm going to pass it off, I think, to John for the closeout and to talk about what we have coming up.
Yeah, thank you, Alex, and thank you everyone else for your presentations today. I hope that our guests found some of your insights valuable. I definitely always like hearing the updates from everyone. For reference, I'm just going to leave this slide up briefly so that our viewers can just have a good reference sheet for knowing what we'll be producing in the year ahead as we start going through the questions. So the first question that we have came very early on, and it was in regards to my father. You mentioned that payers are starting to feel the financial stress. Aren't we still seeing low utilization? So where is the stress coming from?
Okay, first, thank you for the question. Well, where the stress is coming from, first off, you get to remember Q2 and Q3 were pretty profitable quarters for payers, as elective surgeries and the like were deferred. What we saw in Q4, at least from my readings of the various recent announcements from publicly traded companies, is that deferred care was now people were catching up with that and making those visits to their doctors or hospitals or whoever to take care of that deferred care need. So first off, you had deferred care. And secondly, COVID and its shadow We saw the holiday spike in COVID cases across the country. And, you know, when you look at, for example, Anthem's latest results, Q4 results and projections for 2021, they actually stated in their guidance that Medicare rates related to COVID-19, which were increased slightly for physicians because of the burden being put on physicians and providers, those fees, those Medicare rates and fees associated with COVID-19 knocks about 3% off of their projected growth. So originally they were projecting growth between 12 and 15%. Right now they're looking at 9%. So there's 3% cut off there. And Anthem is a very big company. If you look at what United Health reported out, in Q3, only 6% of expenses went to COVID. In Q4, that almost doubled to 11%. So again, that, you know, United Health Group took a hit because of that dramatic increase in COVID cases and having to pay for the treatment of their members that had contracted COVID. And again, you know, on top of that, we don't, you know, in the fourth quarter, we didn't have the lockdown we had in the second quarter. So people were still going back and, you know, taking care of deferred care type things. For example, and one last example is one of the major hospitals here in Boston. Their radiology department is basically running extra hours and running through the weekend to try to catch up on deferred mammograms. They have such a backlog of, you know, patients, cancer patients, patients in recovery or remission that didn't get those mammograms, or patients at risk. And they have to catch up with that. And they can only run so many through what they've got today in terms of the CT scanners that they have and, you know, various testing equipment, radiology equipment. So they have to add extra hours and they're going full bore, right? You know, even today. So I think people have become a little more comfortable with going and addressing those deferred care decisions that they didn't attend to in the spring.
Okay, thank you. And now I have a question that's a little bit more general for the whole team. I know that we talked about the probable growth of shared risk APM type models, but somebody was asking what we think is the future of value-based care.
Well, I'll start. I think we have two choices here. Either hospital systems adopt value-based care models and have some control of what they will be taking on in terms of risk and serving their communities, or they will, you know, the federal government will simply begin coming in and dictating pricing and having, you know, set price rates, and that's it throughout the country. And no one wants to be dictated how much they will be paid. So, you know, it's really up to providers to get on the bandwagon. I think the pandemic showed that, yeah, there's money to be made even during the pandemic if you're in a value-based care contract. So get on with it. I think it's just been a lot of reluctance and a lot of organizations just having a challenging time trying to get moved from fee-for-service to value-based care. It takes a cultural change as well. It's just not flicking a switch. And it's still too complicated, but it'll get better.
Anybody else want to answer? Alex, Jody, Brian, Alex?
Yeah, I think John is largely right. My view is that if you look at where a lot of the growth outside of, for example, existing hospital systems has been, the new entrants have been largely in capitated spaces. They've targeted Medicare Advantage, they've targeted contracted Medicaid populations, managed Medicaid populations. I think with the advent of more powerful analytics, with the ability of tools to really offer cost savings and efficiencies within chronic care populations, we're going to see more organizations and more services focused on that. As we start to see more vertical integration within the market, that's also going to similarly push the envelope. When there's a much tighter relationship between providers and payers, the incentive for an ability of payers to leverage providers into a VBC or a more direct contracting style model increases.
Okay. So I guess the final question is one for Brian. How will the mega vendors evolve in the integration realm? Will they be enablers of more point-like solutions, or will they go beyond that?
So by mega vendors, so mega vendors could mean either the big EHR vendors, or it could mean the Googles and the AWSs. I really feel like the big EHR vendors are uniquely positioned to kind of run the board here. To a large extent, a lot of the smaller point vendors really kind of exist to kind of fill the gaps that the EHR vendors kind of leave. And should they decide to invest in some of those gaps, that could end up affecting the businesses of some of these smaller vendors. If, on the other hand, you're talking about like the big cloud vendors, who knows? It's conceivable that 20 years from now there will be 3 IT vendors: Google, AWS, and Microsoft. It could go the route of the car industry, and all of the other vendors, including the EHR vendors, could merely be suppliers to those vendors. So it's hard to say for sure which scenario is more likely.
Okay, I think that the question is referring to like the Amazons and those such.
Yeah, I every time I look at what Amazon and Google and Microsoft can do, I am blown away. Not because of what they can do necessarily with healthcare, but what they can do with IT.
Okay.
They've got a long way to go in terms of getting up to speed with healthcare, but they certainly have the ability to do that.
All right. Does anybody have any closing comments before we wrap this up? Or are we good to go? Okay, well, thank you everyone for joining us today. As you know, as clients, you have access to the analyst team through the analyst inquiry service. If there's anything that you would like to follow up with anyone around, feel free to reach out to me. Most of you have my email address already. If you don't, it's john3@chillmarkresearch.com, and I can help coordinate something. I hope everyone has a great 2021, and we look forward to working with you in the year ahead. Have a good day, everyone.
Bye, everyone. Thanks for coming.